Welcome to the third edition of the FSOMA News broadcast. We've got David Bibby, FSOMA Vice President and Legislative Chair, talking about some issues, and Jennifer Broadwell should be joining us later with some more updates. And we've got some exciting news about a social media PR campaign. So stay tuned. And thank you to David for joining us.
Thank you, Ellen. And so from where you're sitting, Ellen, can you tell, do we have people that have joined us? And
yes, let me do one bit of housekeeping. If you have a question, please use the chat box. You'll see that on the lower part of your screen or over to the right. But use chat, and that's what I'll be monitoring to put your questions through. And if you can just type in "I'm here" to make sure everybody can hear what's going on, I'd appreciate it. Thank you.
okay, well, thank you everybody who's taking time to join this evening. And I wanted to provide an update on what the Legislative Committee's been working on for the last 3 or 4 months and take questions if there are any. So we've shared some information along the way with the membership regarding one Senate bill and one House bill, both related to Physical Therapy Practice Act legislation this year. In the House, it was Bill 467, and then in the Senate, Senate Bill 792. Both bills included several changes to the Practice Act for physical therapists that was what you'd largely consider housekeeping. They made some changes to the language by including and deleting some certain things. But the reason why we were following the legislation specifically related to dry needling, and one of the things that certainly FSOMA and our membership and the profession around the state is probably aware of is going back to 2012. Here in Florida, there's been discussion either at the board level or legislative level for the past 7 or 8 years regarding introduction of dry needling under the physical therapy scope of practice here in Florida. And at each place along the way, the Florida State Oriental Medical Association has tried to represent the interests of the public in terms of our concerns about safety for any provider or non-physician provider who was, planning on using an acupuncture needle for an invasive procedure. Call it dry needling, call it acupuncture, call it by any other name. This sort of falls under a realm of concern for our profession, both in terms of protecting patient safety and also looking at some structural things regarding scope of practice in Florida as it applies to acupuncturists. So I don't necessarily want to go through every data point between here and 2012, but everybody should be aware that the Board of Physical Therapy has been under the influence of the profession at large, the American Physical Therapy Association, the Federation of Boards of Physical Therapy, to make some language changes in Florida rule to include dry needling. And because of the way the Practice Act was written for physical therapists, and given the historical permissions that are allowed under physical therapy, insertion of an acupuncture needle for therapeutic purpose was something that was clearly outside of the scope of practice for physical therapists. So at first, certain members of the Board of Physical Therapy had disagreements with members of the Florida Physical Therapy Association about whether or not it was appropriate for them to consider rulemaking or consider a position statement regarding dry needling. And this question of physical therapists in Florida performing dry needling did not go very far. The chairperson for the Physical Therapy Board, declined to hear it. They've made several internal rulings that dry needling was outside of the scope of practice of physical therapists. Fast forward a few years, those opinions had changed, and then there was an attempt to go ahead and promulgate a rule, by the Board of Physical Therapy to include dry needling in their scope of practice. That prompted our legal challenge last year, over the last 2.5 years, that ultimately wound up in Judge Stevenson's courtroom. The administrative judge ruled that, as had previously been considered by the board, in fact, yes, dry needling is beyond the scope of practice for physical therapists in Florida, based on existing law, based on the way that the statute is written. So this year, it was no surprise, certainly to somebody who's been following this closely for a number of years, that when the judge explained to the physical therapist board, no, you cannot promulgate a rule for dry needling, not because physical therapists shouldn't perform dry needling, not because they're not trained to perform dry needling, not because acupuncturists don't want them to do it. Those are none of the reasons why the judge found that physical therapists were unable to make a rule for this. Simply put, it was not in the statute for the practice of physical therapy to include this type of procedure. So the obvious next best thing to do is to go back to the legislature and say, look, we need to open our Practice Act. We need to insert some new language and delete some old language that's going to allow us to do this type of procedure, dry needling. So, in fact, not only did they include some more subtle but important changes to their Practice Act just to modernize it, make some language changes, but also use the opportunity to insert dry needling and provide permissions granted by the legislature, granted in law, for them to do that. So since November, we were on notice that there would be 2 bills presented. I described earlier, House bill and Senate bill. And basically what the original version of those bills provided for was simply a permission to dry needle. There was no definition for dry needling. There was no minimum standards of training for dry needling. There was no supervision requirements. There was nothing. Basically just inserting 2 words, dry needling, and then going into a separate part of the statute under with the powers and duties of the board of physical therapy. They granted them specific powers to go ahead and create these minimum standards. So what FSOMA and our attorneys and lobbyists and partners did, looking at what was about to happen under this change in law, was to start to work to educate senators and educate members of the House of Representatives about our concerns. And primarily our concerns revolved around patient safety, and that, if we leave it to the board to decide what this rule will look like, we'll basically see a repeat of the same rule that was attempted to be adopted a 1.5 years ago, which provided for no hours of specified training, no supervised clinical component, no adverse event reporting, no patient consent requirements, and no other data collection. So we expressed our concerns that the legislature really needed to take a leadership role in saying that let's at least include some minimum standards for training and some of these other important components to the law, so that when the Board of Physical Therapy does what it is legally intended and allowed to do, which is to clarify things that are unclear in statute, is that at least a minimum standard of training is established. And of course, there was tremendous debate in the House and the Senate on this question. The House had a far more liberal, if you would, a wide open interpretation that this was really not a legislative concern, that it's the Board of Physical Therapy's responsibility to establish minimum standards. And they wanted no additional language included in the statute. They just wanted to kick the whole thing to the Board of Physical Therapy. And of course, that would be rational and a legal way to go ahead and adopt rules for physical therapy. But we thought that a higher standard, or certainly a higher minimum standard, could be set with some input from the legislature. So we worked with Senator Albritton, who was the Senate sponsor for that bill. And over a period of weeks and months, he came to, I think, agree with some of our concerns, although in a limited way. He wasn't going to take, drastic measures to make, radical changes to the law as it was proposed, but he did go ahead and include some minimum standards of training. And, without his cooperation and without his input, none of those standards would exist. Certainly, this would have just been handed over to the Board of Physical Therapy to do as it saw fit under the law. So what we have now is a bill that requires 50 hours of in-person, live training. It includes a requirement for 25 supervised treatments that are documented. It requires that a physical therapist who is performing dry needling has been licensed in the state of Florida or elsewhere in the United States for a minimum of 2 years. It requires that patients who are receiving dry needling treatments are provided with a separate and distinct consent to treat, which includes the benefits and burdens related to invasive medical procedures with a filiform needle. So certainly some discussion about possibility for bruising, pneumothorax, and spinal hematoma, and the usual critical things that can happen with acupuncture care. So patients will have adequate disclosures about that. And then the last couple of components involve adverse event reporting. Certainly any kind of adverse event that happens from a physical therapist performing dry needling needs to be reported to the Department of Health through the regular reporting mechanisms, and it has to be documented. And lastly, the Senate President here in Florida, as well as the House Leader, have requested that the Board of Physical Therapy provide them with a workforce analysis, basically, that provides the geography and numbers of physical therapists working in the state, and how many of those physical therapists have completed the mandatory requirements for training and supervision before they treat. So that's that was the bill. The bill was voted on unanimously in 3 committees in the House and 3 committees of reference in the Senate. It was adopted on the Senate floor on Tuesday morning with a vote of 39-1, with the only vote against the measure was Senator Hooper from the St. Pete area, somebody who's been a champion for acupuncture for a number of years, and certainly went above and beyond in terms of working with us to help highlight some of our concerns throughout this process. So a thank you to Senator Hooper. But ultimately, what became clear to us, early in the session and throughout the session, was that the legislature has been on a, looking at professional licensure, regulatory standards, and boards of regulatory boards in a way that is unlike anything that we've seen in history. And there was a lot of effort on behalf of the governor under the previous governor, as well as Governor DeSantis, for deregulating a lot of professions. And so deregulation basically is an effort to say, let's reduce the burdens for licensure, let's reduce the cost and oversight for certain professions. And in doing so, what they're really trying to do is create more accessibility for consumers in Florida at a lower cost. But the trade-off is always going to be the competence and maybe hopefully the skill, whether it's a financial planner, whether it's a home inspector, whether it's a healthcare provider. All of these regulated professions are undergoing enormous deregulation standards right now, where the legislature finds it necessary to create more access for consumers to whether it's healthcare or other services, what they think is going to be a lower cost and more convenience. So the question about dry needling and whether or not, it's going to be protected as acupuncture is really moot at this point. For most lawmakers in the state, they look at this as a healthcare access question. They think that, whether it's dry needling or acupuncture, this is a healthcare procedure that can help reduce pain, reduce dependence on medication, and, improve the quality of people's lives in a way that should be available to everybody at the greatest ease and the least expense now. So it is no surprise in the same legislative session where we saw yesterday ARNPs, and I don't know the PAs were included, but certainly the advanced nurse practitioners were granted autonomous practice in Florida. And I think that there's a lot of advantages to that, but certainly the Florida Medical Association expressed lots of concern about how this was being handled to deaf ears. The legislature acted swiftly, almost unanimously, and adopted that language almost overnight. When you look at pharmacists being granted privileges for diagnostic, prescriptive, and treatment privileges for flu and for strep infections, where they're treating in the pharmacy, people that walk right in off the street with 8 hours of CEUs. I think there's another example where the Florida Medical Association was hopping up and down trying to explain to legislators that flu and strep could mirror lots of other conditions. There are false positives, there are false negatives, and that clinical experience and training really matters when it comes to diagnosing, prescribing, and treating these conditions. And basically the legislature turned their back on all of those concerns and said pharmacists are going to be permitted to do this with less than 10 hours of training, overnight. So I think when you look at the examples of what you see with the advanced nurse practitioners, what you're seeing with pharmacists, what you're seeing with physical therapists, it's all part of the same wave of change that's going to affect healthcare providers and healthcare delivery in general. It's going to affect the financial industries and financial services. It'll apply to, like I say, home inspection. I think I had a conversation earlier with Sandra Kahn, and we were talking about risk management. And risk management as a regulated profession and a regulated industry, their board was disbanded. And risk management, it no longer has a regulatory component to it. So risk managers that work in hospitals, that work in municipalities and cities, the same thing that we're seeing in healthcare and in other industries, it's been, on one hand, maybe described as diluted, reduced in some way. And that's one perspective. From a legislative and government perspective, at this point in time, they look at those things as great advantages to consumers, great advantages to cost reduction, great advantages to access to care and access to services at a reduced rate. So what we're seeing in our own particular situation with regard to dry needling through the long lens of how it started and where it's been and how it got to Florida, what's been done successfully and not so successfully, I think that the outcome is really one that should come as no surprise to anybody who has been watching this process closely, not only in healthcare, but across other industries. And, we're going to have to learn to, grow and adapt through this process. There's really nothing much more to it. It's the opportunity is there for physical therapists to use invasive medical procedures like invasive treatment plans with acupuncture needles. It's going to be new to them, and they bear the responsibility for making sure that they're competent and can safely treat. And our responsibilities are to promote and protect our profession and make sure that we're prepared for whatever the next challenges are, and make sure that we're taking care of our own housekeeping at this point, that we're well trained, we're well respected, what we do is well understood, and certainly that's our priorities going forward. So I covered a lot of different things there, but I hope that gives you a pretty good overview of what's been going on and how it's transpired, how it fits into the larger narrative about legislative mood. And if there's any questions about the process and what happened or where do we go from here, I'm open to hear those now.
There are a couple questions, but I also want to say that you and Hong Jian and Min Tian and other members have been working since November almost daily. That David's gone to Tallahassee several times. I'd like you to confirm this. You were told by the House sponsor of the bill that if somehow we managed to block the bill, it would come back the next year with unrestricted access to dry needling.
That's accurate. And this, I didn't hear it directly, but I heard it in a way that is well trusted. Okay. As the conversation about dry needling and acupuncture and physical therapy and the acupuncture profession, as it seemed like that was really the contest was between the two professions. And certainly as somebody who was listening and negotiating and educating and very, embedded in that process, it feels like that you're in a tussle, us against them. But what I came to understand, and this is to answer Ellen's question, is as that process evolved, as the weeks ticked by and there was a little bit of back and forth over what would be the definition of dry needling, how many hours would be required, how many supervised treatments would be required, what would the consent for patients look like, all of these little details as they were being tweaked, they'd be edited by us and then be edited by our physical therapy counterparts, trying to find consensus language, is that finally what the Senator Albritton's staff and himself had come to understand was they would have to go back and forth between the House version and the Senate version of the bill. So I'll try to be brief in how I explain this. When the bills are introduced, there's a version of that bill in the House and a version of the bill in the Senate. And they usually start out the same. And basically what that bill said was physical therapists can dry needle. The powers and duties of the Board of Physical Therapy are expanded to include minimum standards of training for dry needling. That was it. Well, as we were working with the Senate sponsor on the bill, there was an agreement between the Physical Therapy Association and FSOMA going forward that maybe a definition would be okay. Let's define what is dry needling. And then from that, we started working on additional language for what would the training requirements include? What would that look like? How many hours and what would the programs be required? Well, then it went into consent, and then other components and elements of the Senate version of the bill began to take shape and began to take more form. Well, as that was happening, the House bill remained unchanged. And there's a strategy when you're trying to present language for a new law, is that you want to have two versions of that. You want to have the one that's really the simplest version that's most advantageous to whoever is sponsoring the legislation. That would be the physical therapists. And then you're going to have the one that has a slightly more restrictive feel to it, where now we're putting in hours and definitions and all of these other things. So there was lots of movement on the Senate side of that bill, where we went from one line to over 100 lines of new legislation around dry needling. There's lots of definitions and lots of language. The Senate bill wasn't moving at all. And that was partly because the Senate leader and the leadership in the Senate, Jose Oliveira, was very adamant at the early part of the session that healthcare was some kind of cabal. It was what they call the robber barons of the new century, and that hospitals, doctors, medical device manufacturers, they were holding everybody hostage. And he was going to create legislation to put an end to that. So all of these healthcare providers that I mentioned earlier, like pharmacists and nurses and other providers, all fit under that same narrative. So the mood in the House was very, deregulation. They wanted to create as little language as possible to create as much opportunity for people to crisscross scopes as they wanted. So what happened was, in the end, when we were making additional, I say we, I mean the bill sponsor, the Physical Therapy Association, and FSOMA, as we were making changes by including additional components that were required under the Senate version of the law, is that the House president said, look, no more changes. If this bill doesn't pass as is, because we were looking at additional requirements for hours, supervision, a tighter, more narrow definition for dry needling, and a host of other things that we were, I say very successfully at the time, campaigning for. The pushback from the House was, if this bill goes sideways, because it cannot be agreed upon by the parties, it's coming back next year. And the the House president personally said, I am going to sponsor the bill. I'm not going to farm this out to somebody else. I am going to sponsor it. And it's going to pass in the most simplistic version, the original version that basically said the Board of Physical Therapy is going to be in a position to create the minimum standards for dry needling, period, full stop. And it was basically a pushback from the House side of this. This is how I understood the argument to go. It was a pushback to say, we're not going to create restrictive requirements for physical therapists beyond what's already been discussed. And it's not, and I don't know, and I don't want to say that it just applied to the physical therapists. It's probably unfair to say that, because the Senate sponsor had more than 50, I think, related deregulation bills tied into other legislation that they were doing. They're deregulating everybody. I'm telling you, in every sector of regulated professional licensure, they're making efforts to reduce the barriers to practice, to reduce the barriers to perform your professional duties by eliminating boards, eliminating requirements, and inviting more people in. They think of it as, too club-like. You have to have a special high, degree of education in order to do this certain regulated task. And we think that's a bad idea. We think somebody with experience should be able to do that. And all of this regulation and red tape is just making things difficult on consumers. So they're really committed to getting rid of all of that. So Ellen's asking the question, basically saying, if the version of the bill that passed on Tuesday morning, if it failed for some reason, any reason, we had it on solid account that there was strong interest from the House to bring this bill back next year with no refining, no additional input. And basically, we're just going to hand this to the Board of Physical Therapy and let them handle it the way they think that it's best for the profession. Because basically, you have to understand, as acupuncturists, our role, and members of FSOMA and representatives of the association, is to educate. We go up to Tallahassee with high ideals about how we want to influence what outcomes, but that is not really the process. That's not how that works. All you can do is go in and say, hey, I want you to understand these are our concerns, this is why we're concerned, and educate them as best you can, because ultimately they write the law. We don't, and they're going to do it as sort of a consensus process to say, we're going to take, your best input and put it in the hopper with everything else we're hearing and come up with something that moves this ball forward. And what I'm most grateful for Senator Albritton for really in this process, and what acupuncturists should also be grateful for, is this understanding that if for some reason, our worst concerns are realized, and that we see a lot of traumatic injuries to patients who have received treatment from physical therapists with this 50 hours of training, is that would be a bit of a call to action for both the legislators and the Board of Physical Therapy to say, hey, maybe we made a mistake and these thresholds are too low. So by including the reporting, the adverse event reporting requirements in the new law, it's the only country and only state in the country that requires that, is that what the legislature is doing is saying, enough with this argument between the acupuncturist and the physical therapist. Since we have no data that demonstrates that dry needling or insertion of an acupuncture needle is more dangerous in the hands of a physical therapist than an acupuncturist, because no data exists to prove that. Since we don't have it, we're going to create it. If it's out there and people are being injured, we want to know it. And if that data demonstrates that, yes, this is dangerous under the training standards that are being used, then they have a mechanism for increasing the training requirements. And, you know, it's a major breakthrough.
Good. We've got some questions. David, you know, can you pull up the chat box and read some of them?
I rely on you for that, I suppose.
Okay, well, I'll read them to you then. Dave, are you aware of any talk of insurance coverage for dry needling by PTs? Is the term dry needling exclusively for PT use?
Okay, so what I would say is there's no, the CPT code that was adopted by the American Medical Association here in 2020 is not a dry needling code per se. In other words, it's not associated with the term dry needling. It's basically needle insertion without injection. And they have two codes. One is for 1 to 3 muscles, or 1 to 2 muscles, and then 3 or more muscles, or something like this. So the code that exists is a general CPT code where the procedure, if and when described and defined by a physical therapist, that what they did was insert a needle without injection, they can use this billing code. The billing code is an experimental code. It's not, from what my understanding is, it's not been adopted by Medicare yet, or CMS has not approved it under physical therapy. And it's not a physical therapy code per se. It was brought into the CPT code book under surgical procedure. So it's not an acupuncture code, it's not a physical medicine code, and it's not a PT code strictly, it's a surgical code. And it comes under trigger point injection. So after you have insertion of a hypodermic with an injection for trigger point injection comes the next code, and I want to say it's 25060, but I could clarify that for you guys. But that is the code that's intended to be used for dry needling. That was what the physical therapist said lobbied the AMA for. So right now it's an experimental code. It's not recognized by CMS, and as best I can tell, it's not reimbursable. It's still considered experimental. So
they may or may not have coverage when they first start doing
it. My take on that is that it's that coverage is not there yet.
There's several thank yous for all your hard work, which I agree with. If you could talk about the language in there about acupuncture, is there any limitation or guidelines as to the use of?
Thank you. And actually, I just have one other quick thought on dry needling, is that what the AMA puts in the CPT code book when they make this description for that CPT code is, it says insertion of an acupuncture needle without injection, and underneath it in parentheses it says dry needling, comma, trigger point acupuncture, and I want to say it says comma EG, which basically means that this is an incomplete list of those things that may be expressed under that code. So trigger point acupuncture and dry needling were bundled in terms of the meaning under that CPT code. So, I'm sorry, I thought that might be important. And I'm sorry, Ellen, your question.
Oh, talking about acupuncture referred to in the statute.
Yeah. So the way that it was handled is that under the prohibited acts in the chapter 486, it includes that physical therapists may not perform acupuncture as defined in chapter 457. That's the way the language reads.
Okay. There's a question about, and I think this applies to some of our thinking for the future with this deregulation attitude. Is there any movement towards reducing some of the current licensing requirements for acupuncturists from the standpoint of access, adjusting education requirements, removing herbal, or allowing some type of apprenticeship could help bring more people in the profession?
I think, I think that there is sort of a mood and appetite for that. But both when it comes to the board, pardon me, the herbal board question of, say, for example, acupuncture assistants and training requirements, I think some of that can be addressed with the Board of Acupuncture. It doesn't have to be done legislatively through new law. And I have to go back and look more closely at 457, but most of the requirements and qualifications for acupuncture are enumerated in rule, more so than in statute. So if we'd probably come up with a short or not so short list of things that we may want the Board of Acupuncture to consider.
Okay. Right now, Jennifer had a power outage at her house, and she will jump on as soon as she's at her office. I think you could see if there are any more questions on this.
Yeah, please. Anything that comes to mind, guys, I'm open to it.
But we can talk a little about, the deregulation and looking at being proactive instead of reactive.
Yeah.
With legislation. Also, if you could talk a little about just the newest update. I've posted it on the FSOMA announcement page on CMS rules about oversight and supervision.
Right. So one of the things that, when we all read the CMS proposed decision about inclusion of acupuncture for chronic low back pain, the two big questions that loomed in my mind was the definition of supervision under the Medicare requirement, and of course, what's the fee schedule. So we don't have the fee schedule yet because it hasn't been printed, but I did have a chance to ask for some help and direction on better clarifying what the supervision requirement is for acupuncture under the CMS reimbursement, the benefit scheme that we saw. So supervision, there's two components based on the treatment setting. In a hospital or outpatient clinic setting, the supervision, actually, I gotta be careful I don't misstate this. Hang on, just everybody give me 1 second. I have it right in front of me. Okay, in an outpatient hospital setting, services can be performed under a general supervision. And general supervision is basically indirect supervision. It says general supervision means services furnished under a physician's or other practitioner's overall direction and control, but the physician or other practitioner's presence is not required during the performance of the service. And when it says not required, you just basically under general supervision, the physician who is supervising needs to be available under two-way communication. In other words, if you perceive a complication or something is complicated, you can call the supervising physician and get direct input from them based on a two-way conversation. They don't have to be in the room, they don't have to be in the suite, they don't have to be in the hallway, they don't have to be in the building. They just have to be available by communication under general supervision. So this applies to acupuncture that's being performed by anybody who's qualified under that CMS requirement. But this is in an outpatient hospital or CAH setting. The next part says in an office setting. So this is not an outpatient hospital setting. This is in an office setting. Services would be furnished under direct supervision. And the definition for this is in direct supervision, the office setting means the physician must be present in the office suite and immediately available to furnish assistance and direction throughout the performance of the procedure. It does not mean that the physician must be present in the room when the procedure is performed. So you understand what the definition of like an office suite might mean. They want you to be, you know, in the next room, down the hall, but basically probably considered part of the same address, like 100 Main Street, 3rd floor, suite B. You know, your office has to be located there. The supervising physician has to be there as well. So that clarifies the supervision component for acupuncture being performed for a Medicare beneficiary, subject to a Medicare claim. It's going to be performed in one of those two settings. And if there's another unique setting that doesn't fit either hospital, outpatient, or office setting, then on a case-by-case basis, we can try to get some clarification on it. But those are your two general office settings.
Yeah, I know it's been disappointing for a lot of us to have this supervision, but the problem was Medicare didn't have any way to include us right now in the rule because we're not providers in statute. So what they did do is defined us in a way that only we can do it, except for MDs. But nurses have to have our training. They have to be trained in an ACOM school. PTs would have to be, they'd have to have gone through our school to be able to provide this service. So even though it's kind of a bummer right now that we've got to have supervision from an MD, that's the only way we could get put in this rule and be able to do it at this point.
Well, I think that's the distinction for, or certainly a reason for us to go all in to support Judy Chu and stay on board with, Representative Congresswoman Judy Chu is proposed legislation that's going to open and make changes to the Social Security Act that include acupuncturists as Medicare providers. Because that's not, Medicare has lots of sweeping responsibilities and authority and whatnot, but it cannot determine who is and who is not a provider under Medicare. That's the responsibility of the Congress. So they've opened the door, created opportunity, and hopefully they'll create both, need and data and other things that support that this is a really good idea. And that will in turn support legislation in the Congress to say, hey, let's deregulate this just a little bit. Let's give these provider types Medicare provider numbers and allow them to treat in an unsupervised setting. So, it's coming. But right now, as I read that, you're either employed by a hospital or an outpatient hospital clinic, and you're under some sort of general supervision that's related to the clinic, or you have a multidisciplinary NPI, and you're working as part of a multidisciplinary team in an office suite providing acupuncture care, or you're employed by a physician. Those are your sort of options there. Okay.
Well, Jennifer's trying to get to her office where she does have power, so hopefully she can get here and talk some about what's going on nationally and also the trends we're seeing and what we think needs to be done. What I'll do is just talk a little about what FSOMA wants to do. We'd love to hire a big fancy PR firm, but we really need more members. So if you know people that aren't members, get them to join. We've got to get funds to do a big PR firm, but we do have a social media person. Natalia Morrison is doing that, and we're starting a campaign that's going to be #MyMedicine. And the first part is going to be, we'll put it out tomorrow. We're going to be asking you to send us a picture of what it means, what your medicine means to you. It can be a picture of your clinic, your hand with a needle, a wall of herbs, but the hashtag is #MyMedicine. And what we want to start doing is putting out messages that all of us can share about what our medicine is. It's more than acupuncture. It is acupuncture. It is herbal medicine. It is nutritional advice, counseling. It can be Qigong, Tuina. It can be all sorts of things. So we want the public to know that, and we want everybody on their personal and their business social media pages to start putting this out. We complain people don't know about our training. You know, so many people kind of compare us to massage therapists, and you know, we're much more comparison to a nurse practitioner or a PA in
Right.
terms of our post high school training. And with the PhD programs, we're now more comparable to chiros and MDs in terms of how much training. So the public doesn't know this, and they don't know the scope of what we can treat. And I think David got some really great contacts and got a lot of good information to the legislature. So we need to start using that and the deregulation to really improve. So PTs are not sole practice. This new law is terrible economically, and similar to our exclusion from PIP, this means hospitals will have acupuncture without hiring an acupuncturist. I thought dry needling is acupuncture. What about the recent judgment? I don't know if Matthew was here from the beginning or not.
No, that's okay. You know, we can pick it up and without having to redo everything, but I'd love to just sort of, you know, quickly try to explain that. You know, Judge Stevenson's rule was clear in a couple ways. And basically, you know, the rule challenge that we had was not that, you know, physical therapists can't perform dry needling because it's acupuncture. That is true, but that's not something, that's not a legal point that would make any difference at all. The only thing we were trying to do was remind the Board of Physical Therapy that their limited authority for rulemaking does not include creating new law. And by permitting physical therapists to perform invasive medical procedures with an acupuncture needle was a scope expansion. And scope expansion is performed and regulated by the legislature. They write new law. And if they said tonight on Tuesday that physical therapists can do heart transplants, they could do heart transplants. They write the law. They say what's possible. So Judge Stevenson wasn't trying to say they can never perform acupuncture. He was saying dry needling, he said the definition for dry needling in the proposed rule meets the definition of acupuncture. And under the existing language in Chapter 486, the Physical Therapy Practice Act, you cannot do that. And if you can't do that now, you can't create or promulgate a new rule that allows them to do it. That's all the rule challenge did.
Well, the new law also says specifically myofascial pain.
Right. So we did in the definition, we were able to sort of work with the bill sponsor to say, you know, what does dry needling propose to treat? And let's define that. And they say, well, it treats myofascial pain and movement disorders. So, you know, as long, you know, it doesn't say that it treats, you know, GI complaints, that it treats insomnia, that it treats mental and emotional concerns. It doesn't move into the constitutional paradigm. It's strictly for myofascial pain, musculoskeletal or neuromuscular pain, and movement impairments. So these are things that physical therapists already treat. So it's very hard to say that, you know, we're going to restrict them from treating conditions that they're already licensed and trained to treat. They're just giving them a new treatment procedure to use to do that.
So they're not going to have the same scope. Their scope has not been expanded to include biomedical disease or
Correct.
function.
Correct. And actually, there was some other language in their Practice Act that kind of, in this new version that they had proposed, that did expand the practice of physical therapy to include, you know, education and treatment for diabetes and some other constitutional concerns that would be more into the practice of medicine beyond what is typically considered the practice of physical therapy. And I think some of that language did get dialed back, keeping them kind of on the physical medicine platform.
I'm not sure what Matthew meant about sole practice. I know many that are in sole practices, but they're not practitioners of medicine. They're practitioners of physical therapy. So.
Right. But I agree, you know, if this is not the world's greatest news. And I'm not trying to, cherry coat, color, candy coat the issue. Would we want the training standards to be higher? Would we want the practice to be more restricted? We would, because we think that the training should be, commensurate with what's granted in statute. And the training, everybody would agree, is pretty minimal. And it looks like they're given a lot of leeway to do what they want. But that's, like I say, that's the mood of the legislature. And it's not our place to say, no, you can't do that. It's just, that's well beyond ethically what we can do, legally what we can do. It's just not the role of another profession to do that. It's the role of the legislature to weigh the data in front of them, and they ultimately decide. And this is their decision. They, for better or for worse, and we'll know when the data gets, reported. If there's unfortunate examples of people who are injured, then I imagine they'll be revisiting the standards. If there's no, hopefully it's the case, nobody's harmed, then everybody's going to say this, all's well that ends well.
There's, in your opinion, what can we do to expand our own scope of practice to include, for example, IV therapy?
That is, that's a practice of medicine, and we'd probably have to work with the, right now everybody's just throwing it out there and seeing what sticks against the wall. I mean, I'm not opposed to us, contemplating some of these, broader practices of medicine, as opposed to what we have in acupuncture is the limited practice of medicine as it applies to what we do. If we want to expand it into IV therapies, then we have to, I think, look at our training, look at how consistent is it with other things that we have in our statute, and make the argument to the legislature that, we can safely perform, these types of procedures, or, administer things that are injected intravenously. But again, is it a certificate program? Do we approach it like we did with AIT and say, now we were going to do basically injection therapy in an expanded way with an IV drip?
We have some other chats going on I'm responding to.
Yeah, but I would say this, we have, a year or so to contemplate all of those things. And I say we make the longest list that we want. If there's input from the profession that people think they have, specialized training, or we can get specialized training that would, that we can make the case that we could safely administer those forms of medicine, then, I'd be happy to work with FSOMA and the profession and the membership to come up with a list of things that we think belong in our statute, or, belong under our scope of practice.
Okay. Yeah, let's get some suggestions going. Email david@fsoma.org with your ideas.
Please.
There's a comment from Matthew about most of our fame is reducing musculoskeletal pain. And, it's true that we are famous for reducing pain, but it's not just musculoskeletal. And we also improve all sorts of other symptoms people are having at the same time. So we need to be letting that out in our message to people.
Right. I think if Matthew's sort of touching on this point that, if, a large segment of people who identify with acupuncture for treatment of neck, back, shoulder, hip, leg, sciatic, neuromuscular, and myofascial type pain. I agree. My practice is filled with those patients every day. And is this going forward going to change that? Yeah, there's going to be an impact because, for people who have insurance benefits that include acupuncture, that include physical therapy, and physical therapists are going to include dry needling as part of their treatment protocol. They don't have a way to bill for it, but if out of the goodness of their heart, they feel like this is a really important part of their treatment plan and they want to do that, they're going to do it. And so, physicians who make referrals to physical therapists all day long are going to continue to do that. They send people there for all kinds of pain-related complaints. And so people will experience insertion of an acupuncture needle by somebody other than an acupuncturist, chiropractor, or medical doctor. and they'll have a new and unique experience with that. It may be wonderful, it may be less than wonderful, but this is gonna be happening in our communities. And I think as providers, we just have to, warm our mind to the idea that, we're used to people coming in and having tried this and this and this and this and this, and finally they come to acupuncture. Well, they very well may experience dry needling before they come to you for acupuncture, not necessarily realizing the similarities and differences of those two things.
Okay, well, we've got some more things going on. So look for information about my medicine. I can tell you a little about what Jennifer was going to talk about. Nationally, the ASA, and if you're a FSOMA member of the ASA, you are a member of the ASA, is a national organization, and they are working to support national legislation. They have a conference coming up. Let me look up the date. There's information in the last e-news from FSOMA. And it's going to have a legislative day on Monday after the ASA. So the conference for the ASA is the 1st, 2nd, 3rd, and the 4th is a Monday, is a legislative day in the Capitol. What Jennifer has seen is a trend in this country to kind of reduce our medicine down to just acupuncture. And she feels like, in terms of the future, with things like the PTs getting the dry needling, and nurses want acupuncture, other professions want acupunctures, the chiropractors already have it here, that we need to be emphasizing our whole medicine, not just the acupuncture. Find a way to start a campaign to get out to the public about what we can do for them and all the modalities we have. So she has concerns about herbal medicine training, and people a lot of times get out of school, and the acupuncture is much easier for people to identify with and to get results with sometimes than herbs, because of the herb training issues.
Sorry about that.
I'm sure there's more she was going to talk about, but I'm not sure we have time. So I'll get her to send out a little blurb. We'll post it on the website and send it in an e-news about her thoughts. But she's seeing some trends and things that really need to be looked at. So.
I was just going to thank everybody for hanging in for the hour. I tried to cover a fair amount of information and try not to do it in too long-winded a way. Thank you for hanging in with me on that. I also want to assure everybody, I saw quite a few of the messages come across the ticker. Ellen was sharing with me with those. So we had a chance to see all of your comments and, take that under consideration and advisement, and, just continuing to try to, find ways to protect and promote what we're doing and what's most meaningful for the acupuncture and Oriental medicine profession. And, like I say, this is, part of a long struggle over dry needling, and it's a little bit of a mixed bag. I can certainly see where this could have been, I'd say, a lot of more questions unanswered with regard to the legislation. This really taken out of our hands and put into somebody else's hands. And I think we did the very best we could with the options available in the climate in the state. And I really do think that Senator Albritton, for somebody who was really introducing a bill on behalf of another profession, was somebody who in the end was quite rational about the input that we wanted to provide. And he really went out of his way to come up with a version of this bill that, at least in his mind, he thinks provides some protections for the public. And I think as a profession, we should feel confident and prideful that we didn't roll over. We did the very best we could to make sure that the people who were in a position to actually make the responsible decision about how this law would be written, they had all of the best input we could provide. We did it in writing, we did it in, pigeon, we did it in person, and we really did the very best that was possible. And I remind everybody, you know, the lesson, if there is one, is what Ellen was alluding to earlier. If this did not get done in 2020, we would have had a more harsh, simplified, less restrictive version of this in 2021. And there's no question in my mind that that would have been the case. So in the end, you know, I'm grateful for everybody's input. And I hope that we just, you know, we can turn our attention, our efforts, our resources to more interesting things that strengthen and build our profession, instead of trying to swat, you know, at flies all the time, trying to worrying about what other people are doing. That's really not, and has not been, in our best interest. We have a lot more to gain just by focusing on what's best for us, for our patients, and for the public. Okay, guys, that's it for me tonight.
Thank you, everybody. Thank you. Email me, email David at FSOMA.org. Let us know. Thank you.
Thanks, guys. Thanks for all your thoughts.